Hello, good morning, everyone. Assalamu alaikum. It's a great pleasure to see you all. My name is Mohammed Hassanain. I'm a consultant endocrinologist in Dubai, and I'm an honorary professor from Gulf Medical University. It's a great pleasure to have this event. It's, in my mind, it's more or less a historical day to have the first North America Diabetes and Ramadan comprehensive activity. Today's activity is split into two sessions. The first session is a joint IDF and DAR, International Diabetes Federation, and the Diabetes and Ramadan International Alliance jointly together are running the first section, which is a workshop for the best information from the latest IDF-DAR guidelines, which was launched about 3 weeks ago. This is really a very important step, and it is supported by a grant from Sanofi and Servier. I'm delighted that in this particular section, we have a very eminent faculty, but before we move to the faculty, let me share with you the video sent to us by the president of the International Diabetes Federation and the chair-elect of the International Diabetes Federation.
Hello, and it's my great pleasure to welcome you to this workshop on diabetes and Ramadan. My name is Andrew Bolton, President of the International Diabetes Federation, and I'm delighted to say that I've been involved with this project really from its inception. The first international meeting of the Diabetes and Ramadan group was held here in my city of Manchester at the Islamic Heritage Centre of the UK back in 2013, when I addressed that meeting as President of the European Association for the Study of Diabetes. But since 2016, International Diabetes Federation has worked very closely with the Diabetes and Ramadan International Alliance to deliver comprehensive guidelines on diabetes and Ramadan. These are designed to help healthcare professionals advise and support those living with diabetes who wish to fast during the holy month of Ramadan. Patient education is, of course, critical to managing diabetes during this period. Educational needs need to be delivered in advance, so today's workshop is indeed timely. Providing education before Ramadan allows for any questions and concerns to be raised and addressed. These guidelines are, of course, of global relevance. We believe that there are probably around 500 million people living with diabetes across the world today, and this figure is set sadly to rise. The dramatic rise will be seen in many areas of the world with large Muslim populations, including some of our regions, Sub-Saharan Africa, Southeast Asia, and the Middle East and North African region. Because a large number of people choose to fast during Ramadan, there is a significant need for coherent and evidence-based practical guidance to help them and the healthcare professionals who support them to ensure a safe and healthy fast. As healthcare professionals, we need to understand the potential risks involved in fasting for those under our care. And we need to be well informed so we can deliver the latest evidence-based guidance on medication, glucose monitoring, nutrition, and exercise during this period. This second edition of the International Diabetes Federation and Diabetes and Ramadan Practical Guidelines aims to address these needs by providing the healthcare professionals across the world with latest evidence-based recommendations. It is my sincere hope and the sincere hope of all of us at IDF that these will contribute to supporting people with diabetes to safely and successfully participate in Ramadan should they choose so to do. On behalf of IDF, I really wish to thank my good friend and colleague Mohammed Hassanain from the United Arab Emirates for his tireless work throughout these years and in the editing of the guidelines and the distinguished team that he has gathered with him. I should also like to mention my friend and President-elect Professor Akhtar Hussain for his work done in overseeing this project on behalf of IDF. Naturally, none of this could occur without our friends and partners in both Sanofi and Servier for their generous support in making this possible. And of course, I wish to thank you, the participants, who are taking part in today's online workshop. Thank you.
I'm Professor Akhtar Hussain,
President-elect of the International Diabetes Federation and Chair of the IDF Working Group on Diabetes Education. It is my great pleasure to welcome you all to this workshop. Fasting during Ramadan is very important practice for millions of Muslims around the world, but can have a major impact on the management of diabetes. While evidence is limited, some studies clearly show that many people living with diabetes choose to fast. The Epidemiology of Diabetes and Ramadan, Epidemiology study performed in 2010 found that about 43% of people with type 1 diabetes and about 79% of those with type 2 diabetes fasted for at least 15 days during Ramadan. Similarly, the 2010 CREED study reported that close to 95% participants with type 2 diabetes fasted for at least 15 days, and approaching about 65% fasted during the whole month of Holy Ramadan. So we know that people with diabetes will want to fast. However, we also know that an estimated 1 in 3 people with diabetes do not receive the education they need to fast safely. We are here today to help address this shortfall. I'm pleased to report that research on diabetes and Ramadan has increased tremendously over the past 5 years. However, there are still areas where further research will require to improve our understanding and answer some key questions. This can be what, for example, the most effective methods of providing Ramadan-focused education in different populations. What are the best possible nutrition plans for people with diabetes seeking to fast during Ramadan? And how can this be adapted for different regions across the world? Will advances in treatments and technologies help bring us closer to safe management while fasting? For people on insulin therapy who fast during Ramadan, what is the most appropriate type of regimen of insulin? I think we all can agree that diabetes self-management education and support is essential for safe fasting Ramadan. For this reason, the International Diabetes Federation and Diabetes Ramadan International Alliance have come together to raise awareness of the risks associated with diabetes and fasting and deliver the best available advice for health professionals. And this is why we are making the content available to the global diabetes community. In follow-up to the latest guidance you will hear today, we recommend you to visit IDF School of Diabetes website to learn more and access a dedicated free course on diabetes and Ramadan. Thank you all, and I wish you a very successful workshop.
So let's get to business. I know that you're all pretty pressed with these particular difficult times. So let's start with the first session. The workshop, as I mentioned, has eminent faculty. I just need to mention the excellent faculty and perhaps introduce them. We have Professor Osama Hamdi doing the second session from Harvard, USA. We have Dr. Harpreet Bajaj from Toronto, Canada. And we have Dr. Luma Ghalib from Ohio. And then each will do the presentation, and then we'll have a panel discussion. I will introduce each one of them properly at the time of the presentation. So without further ado, let me share with you the first session of the meeting. Okay, so I'm delighted with this small group today that with all people of interest, but as I mentioned, it's a historic day because it's the first meeting across the North America. My session is to cover the benefits and the risks of fasting and risk scoring for diabetes and Ramadan. I would like to acknowledge the co-authors of the different chapters relevant to my presentation for this particular session, including Dr. Bashar Effendi, Munir Al-Arouj, Sheikh Sheikh, Adel Al-Sayed, Khalid Tayyib, Saeed Diop, Yaqub Ahmadani, Suziana bint Zainuddin, and Iba al-Uzayri. So when we think of Ramadan, we think of a very important month for Muslim people. Ramadan is one of the 5 main pillars of Islam, and it is the month where the Quran was revealed to the Prophet Muhammad sallallahu alaihi wasallam. For us, we wait for Ramadan passionately to fast. That passion obviously is shared by the vast majority of people with diabetes, but for some, it might be a cause of concern because they want to share, but they feel unable. So indeed, during the month of Ramadan, there is the spiritual atmosphere, there is the good deeds that so many people do during the month of Ramadan. It's a social event with your community and your friends and family. And indeed, it's feeling the happiness with all of this. But of course, this can lead to, for some, or for the vast majority, happiness, but for some, a bit of stress and anxiety on how can they fast when they have diabetes. What we know from recent evidence that the fasting for Ramadan, even for people with diabetes, is associated with some weight loss. Not massive weight loss, but some weight loss. There is also improvement in biochemical and biometric measures, such as the blood pressure, the glycemic control, and the lipid profile. All these together, as well as the changes in the lipid profile, can help to improve some of the parameters of fatty liver disease as seen in some studies. Unfortunately, because it is only 1 month and then afterwards people go back to their routine, many of these advantages are lost again after a number of weeks post-Ramadan. But obviously, not all is the rosy situation of fasting. For some, fasting when they have diabetes could be associated with hypoglycemia, significant hyperglycemia, that for those who are insulin depleted or insulin absent, the ketoacidosis, and could potentially lead, especially for those working in the heat and in exposed weather, dehydration and the potential theoretical risk of thrombosis. In previous guidelines, we had a table to include some people with different categories of diabetes into one group or the other. The red, the yellow, and the green, or the very high, the high, and the moderate and low. In reality, there was a bit of gap between what we saw in the guidelines and what was happening on the street, because many people who were considered to be high or very high were indeed insisting on fasting, and in many cases they were doing so with no major issues. So it was clear to us that we need to start to think a bit more in depth into what constitutes a risk stratification for an individual who wish to fast the month of Ramadan. And I will here highlight some of these points and let you share with you the thoughts and ideas that I have in my mind. So let's start first with the effect of geography. So Orion study is a study looking into Glargine 300, an observational trial of 500 persons, almost 500 persons. The vast majority of them were from the Middle East and North Africa or from India and Pakistan. There was only 25 people from Canada. What you see in front of you is the percentage of hypoglycemia. And as you can see, almost a quarter of the patients from Canada had episodes of hypoglycemia, while for those from the other region, only 7 out of 477 had episodes of hypoglycemia. Why this happened, why such a geographical difference? We think that a big part of it is related to the hours of fasting, where Canada being in the northern hemisphere, the hours of fast currently in summer months are much longer than other people. The other thing is, when I was working in UK, the fasting carries on with no change into my work pattern. Currently, as I live in the Middle East, the work atmosphere is much accommodated and working hours are reduced to accommodate for Ramadan. So perhaps it's a combination of fasting hours as well as some work and social related aspects that can make a difference between one person here and a person there. And all of this, you obviously live in North America, and you need to take this into consideration. Then it's the point about the type of diabetes. We used to say type 1 diabetes is very high risk, must not fast. But the reality is different, because the reality is only 30% of people with type 1 diabetes from a global survey that included about 1,600 persons with type 1 diabetes and 5,600 persons with type 2 did not fast. Only 30%, which is very different than type 2, which is 16%. But we need to also be careful, because indeed, type 1 diabetes have far much more hypoglycemia in Ramadan compared to type 2 diabetes. I'm talking here about simple symptomatic hypoglycemia and not necessarily confirmed hypo. And that was 62%. So clearly there is a difference. Having said that, we still need to remember that 27% of people with type 1 diabetes fasted every single day on Ramadan, and indeed 27% of them did not have any hypoglycemic episodes. So clearly, while some people can, some other people cannot. And that's our job, to try to dissect who can and who cannot. When it comes to type 2 diabetes, clearly hypoglycemia is related to the type of therapy. This happens in normal days and certainly will be intensified when a person is not eating or drinking at all. So as you can see from these two trials, CREED as well as DAR-MINA type 2, the hypoglycemic episodes increase significantly once we have insulin on board, or if we have some of the types of sulfonylurea, which is more hypoglycemia prone compared to others. But this is quite an important observation that we saw in the CREED study. When you are seeing a person with diabetes in your clinics over the next few weeks, and that person currently has hypoglycemia in normal days, that person is very likely to have hypoglycemia when they fast. That was a much stronger odds ratio compared to any of the other odds ratio, whether level of risk or region, or even indeed being on insulin or not. So obviously when you see that type of person with the pre-existing hypoglycemia, that's the person that maybe you need to think about the risk stratification and adjustment of therapy and so on. What about comorbidities? Do they impact on the fasting, or does the fasting impact on the comorbidity? That's an important question, and we do not have a definitive answer. We have small observational trials, such as this one we did on patients with stable coronary heart disease from my hospital in Dubai, where we saw no increase in cardiac events, no alteration to the BMI or blood pressure or lipid profile or HbA1c. But what was of concern is the significant increase in hypoglycemic episodes of 71% for patients who were receiving optimum care with the best insulin, with patient education, and with flash glucose monitoring. And the flash glucose monitoring data showed us that the sensor that was for 2 weeks during Ramadan showed such a worsening of hypoglycemic episodes. So clearly, we need to start thinking of all of these points. What about age? Well, of course, we do not judge health based on age, but we need to start thinking of what should we do. After all, from the survey data and from other data that we've seen, the person who is older in age is likely to have diabetes for longer duration. And consequently, they might have other health issues that would make them decide not to fast. And that was clear. 28% of the older generation decided not to fast versus 12% of those with type 2 diabetes of below the age of 65. Indeed, needing to go to the ER department or to be admitted to hospital in the older group was over double those who were younger in age. So age matters, but obviously it needs to be taken into consideration of exactly why. So based on all this, we now have a risk stratification score. We have multiple points or factors that we need to think of, and a score is assigned to them, like type of diabetes, duration of diabetes, the presence and the severity and the awareness of hypoglycemia, the level of glycemic control, the type of therapy that the person is on, indeed, whether they have macrovascular complications or renal complications or recent acute diabetes-related complications. Pregnancy is a special situation because a pregnant woman, whether she has diabetes or not, is exempt from fasting, as well as breastfeeding women. But if they insist on fasting, then based on the clinical parameters, we can score. Monitoring of the blood glucose during the month of Ramadan is more important than during normal days. And monitoring appropriately is quite acceptable, but being on insulin or sulfonylurea and not monitoring at all would obviously make the person at an increased risk. Then you look into the duration of the fast, the nature of the job a person does, and the aspects that are related to frailty and cognitive function, as well as age. Someone who is frail or someone with impaired cognitive function and who wants to fast would be pretty dangerous. Living on your own without home support, of course, this could be fine and the person is absolutely able. So the score here is just to guide you rather than a rigid system. And the final point is the own individual experience from the previous Ramadan. So based on all of this, you will end up with a score of 0 to 3, which is low risk, 3.5 to 6, which is moderate risk, above 6, which is high risk. But for us as clinicians, to score is one aspect, but Ramadan, after all, is a religious event. So we need harmony with the religious scholars. And I'm delighted that we have the opinion, the official opinion of the highest religious authorities in Egypt as the Mufti of Egypt. And the Mufti word means the body that provides the regulations for Islamic aspects. And they welcome our scientific input, and they base their opinion based on two important parameters: avoiding hardship and eliminating potential harm. Islam, like all other religions, would not request a person to do any religious practice that lead to harm to their body. Indeed, the readings of the Quran and the teaching of the Prophet Muhammad ﷺ have plenty of examples that we should not jeopardize our health, and we should not let with our own hands throw our health into destruction. So it's important for all of us to remember this. And based on this, a person who scores low, and as fasting is obligatory, they could fast with no issues. However, if you as a healthcare professional felt that this person, because of other reasons, is in need to have regular food or drink or regular medication, then by all means, they are able not to fast. For those who are in amber, 3.5 to 6 points, they are advised to try and fast. But again, if you as a healthcare professional, after careful consideration of their health aspects, you felt that they are better not to fast, they have that exemption as well. We know that many of them insist on fasting. And if they do, then they need to listen to your medical advice and to be doing regular monitoring. Everyone agrees that the person who is high risk is strongly advised not to fast. So this means that we need to have an assessment before Ramadan, and then we need to go through the elements of risk one by one and come to a score. That score could be modified based on some interventions that yourself or your patient can do, and then you can come up with the final recommendation. I hope that these risk scores will be available online and on an app, and I hope that this will be available for us within 2 weeks. Once it's done, we'll be emailing all of you with this information. So what this means is that you need to start doing your assessment now. Every person who wishes to fast Ramadan, and I know in Western societies, we sometimes are reluctant to ask a person about their religion or about their practice. Well, I can tell you, as a person who lived for 24 years in the Western society, if I'm diabetic and the healthcare professional is asking me to help me, it's a welcome question, because perhaps you will offer me some options that will help me to fast rather than interfering with my personal choices. This is quite a delicate issue, but I'm sure with good intention, it could be very well addressed. Pre-Ramadan assessment is very important, and Ramadan education is really quite important. Education is really important. We are all here together as healthcare professionals to learn from each other. Of course, we need also to make the religious community and the community leaders aware about these important points. An imam in a mosque or a community leader in a TV or a radio channel or an article that has the opposite opinion could do a lot of damage. Finally, of course, and more importantly, is the education for the people with diabetes themselves and their caregivers. Education in a meta-analysis has shown to reduce the HbA1c. So it does help and it does matter and can have an impact through more and more months. So we need, during our education, to address the risk, the treatment modification, the regular monitoring, the food and the physical activity, and of course, management of diabetes, and finally, when to break the fast. This is really quite important because it helps people to understand their disease better. Monitoring during Ramadan is quite important. We have 7 important times, but we're not saying that a Muslim person with diabetes must do 7 times a day. The frequency and the timing will be dependent on every individual case. But don't forget that the time of afternoon to evening, so from late afternoon to sunset time, this is the time that the person with diabetes, when they're fasting, are most vulnerable to have hypoglycemia. And checking routinely at that time will help to prevent and predict and detect hypoglycemia. But we should not ignore hyperglycemia. Ramadan sometimes is a month of feasting, and having the testing during the eating hours is also very important. Detecting the symptoms of hypo or hyperglycemia are quite important, as well as the regular monitoring and the advice to the patient to stop the fast immediately if they have sudden hyperglycemia or indeed hypoglycemia, symptomatic or non-symptomatic. Education, of course, is quite important, and the IDF, along with DAR, have last year launched diabetes modules for Ramadan. These were extremely successful and extremely helpful, and they will be updated and available for all of you to log in and to go through it soon. We also have 2 different applications. One for patients called DAR Safa, and Safa is the short of Safe Fasting. And feel free to download it. It's a free tool available for everyone, and you will have in it many information in English, in Arabic, in French, and in Urdu. Plus, there is also the healthcare professionals app as well as website. So in summary, ladies and gentlemen, fasting during the month of Ramadan is a religious obligation for all healthy adults. However, the Islamic regulation has exempted those afflicted with illness from this obligation. Many people with diabetes can fast safely, but some would fall under this category of they are exempt from that obligation. Our job as healthcare professionals is to go through every individual parameter and risk stratify for our patients in advance of Ramadan so that we can provide them with this information. Luckily, this decision of the risk certification is supported by the regulatory authorities from Egypt, and I advise you all, if necessary, to take that locally as well with your religious authorities. Individuals who fast against advice provided by healthcare professionals should really try to seek the best expert advice so that they can do so without any serious complications. Pre-Ramadan assessment and education is an essential tool for a safer Ramadan. Here are some of the references I used, but obviously the ultimate reference is the IDF guidelines itself, along with DAR, which is available as a free download from the website. I'd like to thank you all, and I would stop here and introduce my very good friend and colleague, Professor Osama Hamdi from Joslin Harvard in Boston. Professor Hamdi will be talking about the practical consideration for type 2 diabetes for patients on oral hypoglycemics and GLP-1. Professor Hamdi is well known for his vast amount of the clinical experience as well as the research into the field of prevention of diabetes, obesity, as well as he's been quite active in the field of diabetes and Ramadan, and he has contributed to the last two IDF and DAR guidelines. Osama, I know if I were to introduce your full CV, it will take the full meeting. So I hope you are okay with this very brief introduction.
Assalamu alaikum wa rahmatullahi wa barakatuh. So, good morning. I would like first to thank Dr. Hassanin for his tremendous effort over years to produce a wonderful group that worked hard over years to present a safe diabetes and Ramadan practice. You know, after many years of presenting this in many countries across the globe, and also in some pockets in the United States, I am very fortunate that this will be for the first time broadcasted to a larger population of primary care providers and specialists in the United States. So I'm very, very pleased to be part of this and present to you some of the information that we worked on for over years. And in my presentation, which I believe will be very important for every one of you, we will cover four main aspects: nutritional intervention during Ramadan, and also we'll talk about oral hypoglycemic medication, GLP One Analogues, and patients who are on multiple medications. So let me start first by thank the wonderful group who worked on this chapter of the guidelines. They tremendously helped us: Wasim Hanif, Muhammad Hassanin, Tariq Al-Haddad, Nazir Ahmed, and Nisak Yusuf. So let me start first by one important aspect of Ramadan. We all know that we alter nutrition during Ramadan significantly, not only by fasting, but also in the way we eat and what we eat and when we eat it. Those are major issues during Ramadan. But before we even start, I would like to remind every one of you that Ramadan is an intermittent fasting. So there is a huge benefit from intermittent fasting in people with diabetes and in people who are also with pre-diabetes. And we know that improve insulin sensitivity, reduce intrahepatic fat, improve hepatic steatosis, improve blood glucose level to a great extent, and people also lose weight. So why we have problem during Ramadan? I put on this slide some of the practices that people do that make it very difficult to control diabetes in Ramadan. One of them is eating larger meals. More than 1,500 calories can be consumed in just one meal. People are fasting during the day. They have intense hunger, and then they eat significant large meal. Large amount of processed carbohydrates and sugar. People immediately when they feel low blood sugar, they would like to compensate and quickly raise their blood sugar up. Sugary desserts, which is traditional during Ramadan in many countries. They eat certain types of desserts that has significant amount of sugar. Large and frequent snacks between iftar and suhoor. People are keep eating snacks, sometimes are larger, and mostly they are carbohydrate based. People, when they come to their meal, sometimes are eating very quickly. And this is a very bad habit because you cannot suppress appetite quickly. You need like 30 minutes to suppress appetite by food, but in the same time, it raises the blood sugar significantly. Some people eat early suhoor because they are afraid to miss it, or to they don't like to wake up early, late to eat suhoor. This is again another problem. Large amount of high glycemic index carbohydrates at suhoor, because people are in fear that they will have no energy during the day, so they consume significant amount of carbohydrates. In many places, people are eating certain types of fried food and food which is high also in trans or saturated fat. And then you know that there is a change in exercise and eating and sleeping pattern. So there is a lot that can lead to hyperglycemia, hypoglycemia, and dehydration during Ramadan. So what we suggest, and as Dr. Hassanein mentioned, in Ramadan, there is a very important pre-Ramadan assessment. And I personally believe that if people do some practice, fasting 3 days in Sha'ban or maybe in Rajab, and see what the fasting will have an impact on their eating and their medication. This can be very, very valuable. Guidance on medical nutrition therapy that can improve glycemic control, and I will give you some lead on this. Of course, we don't have time to cover the entire topic, but I will give you some idea where you can find some resources for that. And then provide information on how to prevent dehydration. Mind that intermittent fasting, typical intermittent fasting will allow water and beverages, but during Ramadan, people can be at risk of dehydration, especially if they fast for longer hours or in hot days. Individualized nutrition plan can be very important because you still need energy during the day. And also, some people will love to lose weight, and I think Ramadan will be a wonderful opportunity for people to lose weight. If people do it very well, they lose between 2 to 4 pounds just by the fasting. So regarding the typical nutrition that we suggest in Ramadan, it depends on, are you looking for weight maintenance or you are looking for weight reduction? So if you, for example, is a man and you would like weight maintenance, your meal should be between 1,800 to 2,200 calories per day. If you would like to lose weight, then stick with 1,800 calories to lose weight. For women, between 1,500 to 2,000. And if they would like to lose weight, stick with 1,500. Shorter women who are shorter than 150 centimeter, then they can go with 1,500. But if they would like to lose weight, they will stick with 1,200 calories per day. We provided meals that has 1,200, 1,500, 1,800, and also 2,000 calories. And I will, in a minute, show you how you can get those. But the whole idea is to give around 40 to 50% of the entire caloric intake, nearly half of the entire caloric intake for iftar, around 30 to 40 in suhoor, and then you can get 2 snacks during the day if you like, or 1 snack, and each one between 10 and 20. So it depends on how you make the distribution. You will end up with balanced meal during the day and the full 100% of the calories. The easiest way to use in Ramadan is what's called Ramadan Plate. And Ramadan Plate, you will have a lot of information about Ramadan Plate, and you will find it in the DAR Alliance. As I mentioned, we have many meals designed for several parts of the world. But this is an example of a meal, which is 500 calories. And you can see you can split the plate into 4 quarters. In 1 quarter, you'll put the vegetables. And in 1 quarter, you will put the protein, can be like 3 to 4 ounces of meat or chicken or whatever, fish or any kind of protein. And then the starchy part, whole grain, rice, if you are in area that eat rice, or in some other places that use other type of carbohydrates, This will be 1/4, and then the last one could be legumes, could be cooked vegetables, and so on. Water is very important, 2 glasses of water. Oil, which can provide very good healthy fat in the form of olive oil mostly, or canola oil. And then it can be a small slice of fruit as a dessert. We developed in 10 countries different meal plans. You can find all of them as daralliance.org. You can download the app. You can ask your patient to download the app. The app will guide them. If you would like to lose weight, maintain weight, what caloric level. They will divide all the meals for them, and they will guide them and give them 7 examples of meals that they can use. So now let us move to the oral medications or medication in general for diabetes. I will cover most of them except insulin. And as you all know, what is the major aim here is to get a better glycemic control without hypoglycemia. Definitely, this cannot be achieved very well unless you have a very good nutrition and you have some adjustment of medications to prevent hypoglycemia, and especially medication that induce hypoglycemia and medication that cause dehydration. So let me start with the first and common medication that we use every day, metformin. And definitely metformin is one of the medications that doesn't cause any hypoglycemia. It causes some little weight loss, and it reduces significantly the fasting plasma glucose because it suppresses hepatic glucose production. So if someone is using once daily dose, there is no dose modification, and you take it with iftar. Remember that the major time that you take your medication is usually iftar. So if it is once a day dose, take it with iftar, no adjustment. If it is two daily dose, morning and evening in the usual way, then again, no alteration, and you will take it with iftar and suhoor. No change. If someone is taking 3 tablets per day, say 750 milligrams 3 times or 850 milligrams 3 times, then 2 of the tablets will be at iftar and 1 will be at suhoor. So the larger dose, as I mentioned, will be with iftar. And if someone is taking long-acting extended release medication, take it at once, then they will take it with iftar. So it's very simple, very direct. Take the bigger dose with iftar and the smaller dose, if needed, with suhoor. Now, risk of hypoglycemia is low. There is another medication that's used mostly in the Middle East area, not that much in the United States, acarbose. As again, acarbose is one of the medications that reduce carbohydrate absorption. It doesn't cause hypoglycemia, cause some weight loss. The major issue in the United States, as all of you know, that people don't like it because of the polluting and the gases and so on. But the medication is safe. No change in the medication, no dose alteration if you are using acarbose in your patients. Now, moving to short-acting secretagogues, cerebaglanide and all the glanides in general, those medications are short-acting secretagogue. They, in reality, don't cause that much hypoglycemia. So studies that had been done in using those medication, they found that the chances for hypoglycemia is significantly low. So the daily dose is not altered. People will take it with suhoor and take it with iftar in the same way. But you have to be sure that you distribute your meals in the right way and distribute the medication equal between the suhoor and iftar. Now, coming to DPP-4 inhibitors, again, many studies had been done, and most of those studies compare the DPP-4 inhibitors to sulfonylureas, and as you may expect, hypoglycemia were more with sulfonylureas and much less with all kinds of DPP-4 inhibitors. So those are kind of safe medication that can be used, in Ramadan without alteration of the dose, whether you are using sitagliptin, saxagliptin, allogliptin, linagliptin, and vildagliptin is not available in the United States, but available in many other places across the globe. So DPP-4 inhibitors, no change in any dose, and you can give it with iftar as well. Now, coming to sulfonylureas, and as you may expect, sulfonylureas is one of the medications that we have to be very cautious about them because the chances for hypoglycemia is significantly high. But I would like to just mention that older generation sulfonylureas like glibenclamide has more effect on blood glucose level and more hypoglycemia in comparison to the newer ones, gliclazide, glipizide, and glimepiride. Those medications are less in their hypoglycemia. And you can see in a study that compared all of them, gliclazide 14% hypoglycemia, glimepiride 16%, and then glibenclamide, which is glyburide in the United States, is 25%. So there is some adjustment that we need to do in those medications, and maybe it is a good idea also to switch from glyburide to glibenclamide, to glimepiride or gliclazide if gliclazide is available. But in the United States, we only have glimepiride, glipizide, and glyburide. So switch from glyburide to glipizide XL or glimepiride. So again, many studies, I can show several studies, but the bottom line is that in Ramadan, you have to be very cautious about this medication, and they need to be adjusted. So let us jump to how we will adjust it. If someone is taking once daily dose, you take it with iftar, but you have to look on the previous months or the previous 3 months, how the A1C was. If the A1C was in a very good control, or the blood glucose level or the CGM is telling you that the person is in very tight control, you may think of reducing dose. So from 20 to maybe 10, from 10 to 5, from 5 to 2.5, you can reduce the dose if you are in glimepiride from 8 milligram to 4 milligram, from 4 to 2, or from 2 to 1, if the person is well controlled. But the dose is taken with iftar. If the dose is taken twice daily, and a lot of patients are taking it twice daily, then the iftar dose will be the same, but the suhoor dose in people who are also well controlled should be reduced. So you keep the iftar dose, you reduce the dose with suhoor. As I mentioned, older sulfonylureas, glyburide, and outside the United States are glibenclamide. It is better to make that switch. Now, what about SGLT2 inhibitor? This is a recent block in the diabetes management. Very effective medication, helping people to lose weight. But there is concern, and the major concern, I believe most people will say, is dehydration. And this can be manifested in reduction in blood pressure, in postural hypotension, in reduction in renal perfusion, and so on. But studies actually which had been done to compare several SGLT2 inhibitor with sulfonylureas and many other medications found that actually hypovolemia and hypotension is minimal. So for example, it was only seen in 16% in people with SGLT2 inhibitor in comparison to 5% in people on sulfonylureas. Feeling thirst was in 13% in SGLT2 inhibitor in comparison to 6%. So it is nearly double than what you can get from sulfonylureas. But again, the 16%, 13% is giving us impression that in many patients this can be effective. So here, for example, you have 87% didn't get that feeling of thirst. And again, postural hypotension had been reported in 13.8%. So the conclusion is that SGLT2 inhibitors have low risk of hypoglycemia. No need for any dose adjustment during Ramadan, but you have to be careful and evaluate. I always assume that you will not start the SGLT2 inhibitor at the beginning of Ramadan, and should be at least a few weeks or 1 month before Ramadan, and this will be a good practice so you can see what is the effect. SGLT2 inhibitor are recommended to be administered in the evening meal with iftar, not in the morning as we usually do, because you don't need people to be urinating too much and getting more dehydration. Of course, you need to hydrate your patient very well, and especially in the areas with longer day and with hot weather, you have to ask them to drink a significant amount of water and fluids during the period when they are not fasting. And I personally recommend between 6 to 8 glasses of water to be consumed. Then we need now to raise awareness about this new guidelines, because SGLT2 inhibitor were not in the previous guidelines, and it is an important medication. And then when you are using any anti-hyperglycemic therapy, the impact on heart failure and renal function must be considered. And medication that has a positive impact on congestive heart failure will be recommended for those people with congestive heart failure. And also, we know that SGLT2 inhibitor are medication that protect heart in people with previous heart problem, and also have some good impact on kidney function. And again, it's better to start those medication earlier and use all the precautions as usual. Now, coming to GLP-1 analogues. Again, those medication are widely used, whether they are daily use or weekly use. Medication are very effective in reducing blood glucose level and also suppress appetite. Some people find it very useful during Ramadan, especially if they are planning to lose weight. It controls their appetite to a great extent. It is not like cheating in Ramadan, but it is helping in controlling appetite and reducing hunger. Again, all the studies that had been done so far showed the medication is not causing hypoglycemia, unless, of course, it is used with sulfonylureas or used with insulin. So there is no need to reduce or change those medication during Ramadan, but you have to start GLP-1 a few weeks before Ramadan, or maybe a month or more. I prefer a month or more before Ramadan, so any nausea or vomiting or any other side events will be controlled. Remember to hydrate your patients very well. Some of those medication may cause constipation, especially the newer one, semaglutide and dulaglutide. So maybe it is a good idea that you hydrate your patients, observe for kidney function as well during Ramadan. Now, finally, what about the person who are multiple anti-diabetic medication? This is a little bit a dilemma, because there is a lot of people who are now or not 4 medication, or maybe 5 medications, or even with insulin. So you have to be very careful about those people. Many individuals are taking multiple medication, and many of those people have longer duration of diabetes, have other comorbidity like renal impairment. So the risk of hypoglycemia will be higher when they are fasting during Ramadan. So you have to be careful in people who are taking multiple medication. So individuals who are with type 2 diabetes and taking 3 or more medication and fasting during Ramadan should have a comprehensive counseling before Ramadan or the beginning, and they should have some advice about diet, about lifestyle, about drug dose modification. Those are very important to be prepared and done before Ramadan. Again, reduction of insulin is used with those medication will be a very good idea. Sometimes we reduce insulin by 25 to 50%, in those people, but you have to be very careful also if you are using sulfonylureas. So again, pay a lot of attention to people on multiple medication. Use newer technology. You have now CGM in many places. In US, it is widely used. I highly recommend using CGM in patients during Ramadan. They can, if insurance doesn't cover it, out of pocket, they can pay for it just for 1 month. It will not break the camel, so they can use it. They can safely tell them, and also it can alarm them on hypoglycemia and severe hyperglycemia. It actually improved lifestyle significantly. And I wish in the future we'll put CGM as one of the guidelines in use during Ramadan. So in summary, the application which Dr. Hassanein mentioned and I mentioned, try to use it for your patients. It is very, very good guide. It is in different language. It has many meals examples. Regarding medication, I need just to tell you there is advantage and disadvantage of all medications. So you have to show them during Ramadan in a very careful way. Individual on metformin, sulfonylurea, cigarettes may need to take the medication with some dose adjustment regarding the dose or the time. This is very important. People who are on multiple medication are at greater risk, and we have to evaluate them carefully before Ramadan, adjusting their medication, especially sulfonylureas and insulin. And I would like to say that SGLT2 inhibitor is one of the newer medication, and it is safe. Hypotension and dehydration occurs in smaller number of patients, so don't be afraid that much about using them in Ramadan. Post-Ramadan, you need to counsel your patients again and make a good regimen. Dr. Hassanein mentioned something which is very important. Ask your patient usually about their previous experience in the previous Ramadan. If someone has hypoglycemia, more problems, usually guidance by previous experience. Ask people to fast some days during Sha'ban and see how they will do. Again, support from you to your patients is paramount. It is very important. It will help your patient to have Ramadan in a safe and effective. Try to help your patient to get the benefit of Ramadan and avoid all kind of risk. With this, I would like to thank you so much for your good listening. Here is many references. You can get through them and they will help you a lot. Thank you very much.
Thank you very much, Osama, for the very clear presentation. It's really quite important, the messages that you have mentioned. And obviously, in the second part of our meeting today, we'll have more hands-on clinical cases. So keep sending your questions, everyone. We'll answer the questions at the panel discussion. So we now move to the third session of this IDF-DAR workshop on insulin modification during the month of Ramadan. And I'm delighted that we have with us today my good friend and colleague, Dr. Harpreet Bajaj from Toronto, Canada, who will address this topic. Harpreet is known to many of you. He graduated from New Delhi and then moved to the States for his postgraduate studies and specialization in endocrinology, and then moved back to Canada, where he was working in Mount Sinai Hospital, currently in Toronto. He's an adjunct lecturer at Macmaster University. He's also the director of the late phase research at LMC Healthcare, and he's on the executive board of Diabetes Canada. We have collaborated together in the position statement, the recommendations from Diabetes Canada on diabetes and Ramadan a few years back, and I'm delighted that Harpreet was able to join us on the latest IDF-DAR guidelines. Harpreet, over to you, my friend.
Thank you so much, Dr. Hassanein, for that kind introduction and for this invite to discuss the injectable portion of therapy. So I would like to first of all congratulate Dr. Hasnain and the whole team on bringing the IDF-DAR sessions workshop to North America. Of course, Dr. Hasnain and the team have been instrumental in changing the landscape of education in this area and making it more scientific, evidence-based, as well as sharing the experiences so that people, we can help, we as healthcare providers can help people, Muslims fast during Ramadan carefully and safely as well. So congratulations on another update on the diabetes and Ramadan guideline to the whole team. In regards to insulin therapy during Ramadan fasting, first of all, my disclosures, I don't have any relevant disclosures, but for full disclosure, here's the speaking or research or other conflicts that may be perceived. The outline of what I'm going to talk about is here. So I'm going to focus on the insulin therapy. First of all, do people with insulin have a higher risk? And if so, should they be guided not to fast, or are they automatically considered high risk? What should the guidance be in regards to that? We'll talk through some of the specifics of insulin therapy, so insulin analogues versus human insulin, which regimen may be better, and how to adjust therapies for different insulin regimen. And then what's new in the guideline, because there is new updates and new research studies that have been incorporated in the guidelines as well, and that'll be discussed. So first of all, in terms of what's new and risk stratification is brand new, as Dr. Hasnain already went through. In insulin, people who are on insulin, do we automatically think that they should be considered high risk or increased risk or not? Now the risk is weighted according to the regimen they are using, in addition to all the other factors that Dr. Hasnain already mentioned. Again, it's the count or the numbers that you get according to the risk factors that you count to a total of 6 or more makes people at higher risk for Ramadan fasting. And among those, if you look at the insulin regimen itself, the basal insulin gets the least amount of points, so it's 1.5 points. If it's once daily mixed insulin, it's 2 points. If it's basal bolus or insulin pump, it's 2.5. And the multiple daily or twice a day, 3 times a day mixed insulin injection gets the highest number of points for that. So that's 3 points. In comparison, you can see some of the sulfonylurea, which also leads to a higher risk of hypoglycemia, as Professor Hamdi mentioned, are given 1 point for the glibenclamide or glyburide, and then other sulfonylureas get 0.5 points. So that's about the risk stratification. Is there evidence now that people with type 2 diabetes who are on insulin can fast, and what is the risk of hypoglycemia? Professor Hasnain already mentioned the DAR-MENA type 2 diabetes study. And I'll just highlight, first of all, if you start from the oral anti-diabetic agents, sulfonylurea, if they don't have sulfonylurea, which is the first set of the bars, then they have a very low risk, the gray being during Ramadan hypoglycemia, and the dark gray being the 4 weeks before Ramadan. And then if people are on sulfonylurea, their risk is higher. So you can see 0.19 confirmed hypoglycemia events compared to 0.04 before Ramadan for those on sulfonylurea. And of course, with insulin, the risk is higher even before Ramadan, but especially during Ramadan. And this is what we are focused on in this presentation. In terms of which insulin, does it matter which insulin is being used, and does the hypoglycemia risk vary or not? This is a recent publication from, again, Professor Hasnain's group, looking at FGM. So flash glucose monitoring was used, and comparison was between a basal insulin-only regimen, about 26 people on this regimen, compared to intensive insulin therapy regimen, 23 people in this regimen. If you look at the FGM hypoglycemia duration, as well as the number of hypoglycemia, which was less than 50, or even in the 50 to 60 range, the numbers numerically were lower in the basal insulin group compared to the insulin therapy group, but these did not reach statistical significance. In terms of hypoglycemia timing, and this becomes important during the fasting time, of course, it was the afternoon and evening time. So between 12 noon to 6 p.m., so before iftar, is when the hypoglycemia was much lower and statistically significantly so for people who are on basal insulin compared to intensive insulin therapy. So that was the difference in terms of hypoglycemia that was seen in the evening or afternoon time, which was significant on the fast glucose monitoring on basal insulin therapy. So that's about hypoglycemia risk and how to individualize hypoglycemia risk in general. Now, how to adjust insulin therapy so as to minimize this risk of hypoglycemia. Of course, there are many options, and as clinicians, we have to always think about individualizing therapy, individualizing treatment according to the person that we are caring for. Options may include continuing current therapy or continuing what they did during the last Ramadan, the last year, adjusting doses, adjusting timing of doses, changing to different drugs or different combination or regimen, or a combination of all of the above. Here's some practical considerations as well. In addition, if you look, so many individuals on insulin, we know, elect to fast irrespective of their risk level and advice of physicians. And as Dr. Hasnain already mentioned, that was one of the reasons for the new risk stratification that has been adopted in the new updated guidelines. And the primary focus, of course, is reducing the risk of hypoglycemia. But then there should also be important considerations regarding maintaining at least the glycemic control during Ramadan, not letting too much hyperglycemia affect the person's health as such. Now, the insulin regimen must be individualized, and education and preferences and diet and lifestyle play a role. And all of this has to work as a combination and not just changing insulin without further education or discussion of diet. So it has to be a comprehensive Ramadan education program that has to go along hand in hand with this. Also, the individual's pre-Ramadan glycemic control, whether they've had hypoglycemia episodes or not in the past, and what was their previous Ramadan experience. If they were on the same insulin regimen, maybe needs to be taken into consideration when you determine how to change or adjust their regimen this time around. Now, some authors do recommend, if, for example, somebody's on a premixed insulin, which, as we saw, is the highest risk, at least according to the risk assessment, maybe consider changing the premixed insulin to a longer-acting insulin and maybe a basal bolus, modified basal bolus kind of therapy. But then there are caveats to that as well. There may be some downsides because this would mean, this would be a new regimen for the person just for that 1 month of the Ramadan period. And then that'll need additional education. There may be some non-adherence, maybe some misunderstanding can creep up, and that has to be considered as well. So let's talk about each of the regimen in silos, if you will. So starting with basal insulin therapies. So most of the recommendation in basal insulin therapy are based on observational studies, and most of them have used analog insulin, so Glargine U100, for example. So that's what I'm going to discuss. So there's no randomized control trials that have been done with a basal analog insulin compared to, say, a human NPH insulin that guides this guidance. Also in red, you can read that this is sometimes a misunderstanding among people that is administration of insulin. Does it in any way break or not be conducive for Ramadan fasting? And that's not the case as such. So administration of insulin is allowed and does not cause a breaking of a Ramadan fast. Here's a couple of studies, observational studies with the glargine U100 insulin. So again, these are observational studies that show that the risk of hypoglycemia was not, at least not significantly higher during the Ramadan period, and no major changes in terms of glycemic control were observed. Here's a couple of additional studies which have a comparator in addition. So there's at the top, you can see this study by Seisher et al. From Turkey, comparing basal insulin glargine U100 to sulfonylurea or glimepiride or ribavirin regimen. And they found that individuals had no significant differences between the treatment groups, whether on glargine insulin or on sulfonylurea. The hypoglycemia rates were similar, and no severe hypoglycemia events were recorded. And then more recently, there's this Orion trial that Dr. Hasneen already mentioned. And I must say that Canada was, this was the first Ramadan study that Canada and me and LMC have been involved with. So it's, I think it's in many ways eye-opening to be part of a research in Ramadan with diabetes and with this trial. But Orion trial is with glargine U300. And the majority of the patients who were in this study had discussed and said that they intend to fast throughout the full month of Ramadan. And what was found in this observational single-arm study was that glargine U300, there was a low incidence of symptomatic hypoglycemia, and there was no episodes of severe hypoglycemia. Also, the glycemic control, if anything, was improved after the Ramadan period, with the A1C improvement of 0.3%, which was statistically significant. Body weight was reduced as well. So this is a new update on the studies, the evidence that we have for basal insulin analogs as such. Then the next question becomes, what happens after a basal insulin? So if somebody needs additional therapy, is GLP-1 receptor agonist, is there any evidence for that? Or do we need to think about prandial insulin during Ramadan? And here's two studies that have been published using basal insulin and GLP-1 receptor agonist together, not as a fixed ratio combination, but separately as such. The topmost is the liraglutide plus insulin. There was no comparator. This was an observational study, and the risk of hypoglycemia was about 16%. The bottom one is a study that Dr. Hasneen led, comparing lixisenatide plus basal insulin against a comparator of sulfonylurea. And they found that there was a lower rate of anytime hypoglycemia with the lixisenatide versus the sulfonylurea group. So about 4% compared to 17%, which was statistically significant. And that was without any worsening of glycemic control overall. So here's the flow chart or the forest plot for that study. So in the pink column, you have the lixisenatide plus basal insulin. In the light blue column, you have the sulfonylurea and basal insulin. The primary endpoint was documented symptomatic hypoglycemia, less than 3.9. And as you can see, the numbers were very small, even though it trended towards less events in the lixisenatide group. This did not reach statistical significance. However, anytime hypoglycemia, the numbers were slightly larger, and hence there was statistical significance that was found in favor of the GLP-1 receptor agonist compared to the sulfonylurea when added to basal insulin. So that's about GLP-1 receptor agonists. How about a prandial insulin? That's what this study is about. So this study compared Lispro insulin. This was a crossover randomized trial comparing against human insulin R. And what they found was this analog insulin Lispro may reduce the risk of hypoglycemia. Also, the potential for lower risk of postprandial hyperglycemia was found at 1 hour and 2 hours after the meal as well. So that was a study which is a randomized trial that shows possibly the benefit of using analog prandial or bolus insulins compared to human regular insulin, especially during Ramadan period. The other practical point about this is the third bullet point, which is that insulin analogs are injected just before a meal, or even sometimes can be injected after a meal, which during Ramadan is fasting time is useful, especially with iftar time, because you can inject right at the meal or right after the meal. On the other hand, regular insulin will need to be injected 20 to 30 minutes before a meal, and so that may become challenging as well. So that's about prandial insulin. Last but not the least is the premixed insulin. So premixed insulins, of course, have the higher risk, as we saw in that risk assessment. Of course, the problems with premixed is the inflexibility of the insulin itself. There's maybe inadequate prandial coverage during the iftar meal, which is the larger meal, and hence low combination, low ratio premixes like 30-70 or 25-75 may not be enough to control the post-iftar hyperglycemia. And also they may, because of, again, the inflexibility, they may lead to more hypoglycemia after the early morning meal, the suhoor meal in Ramadan, because of that inflexibility as well. But again, if this is the regimen that the patient, your patient has been on, then we'll talk about how to adjust this regimen for that. There's also the alternative options of using a higher ratio premixed insulin, especially at the iftar time. So a mixed 50 kind of regimen at iftar may control the postprandial hyperglycemia better during that meal, or changing to a basal bolus or a basal plus GLP-1 receptor agonist, if that is feasible, may be considered as well. In terms of, again, premixes and using these together with basal analogs, there have been two studies. The top one is biphasic insulin aspart, so a premixed insulin together with a detamir insulin. The idea being there will be some basal throughout the day, whereas the premix would hopefully take care of the iftar hyperglycemia and to some extent the suhoor hyperglycemia as well. So this study showed that there was a limited risk of hypoglycemia compared to standard of care treatment, which was the ADA recommended insulin regimen, and this was statistically significant. And more recently, again, Professor Hasneen et al. Led this study with a fixed dose combination of degludec and aspart insulin. This combination fixed dose, I believe, is not available in North America, so not in Canada, and I believe not in the US either. But this is the only randomized trial evidence that we have with a basal insulin analog, if you will, which has positive outcomes. So this study, which was a well-done phase 3 open-label randomized trial comparing against a biphasic aspart insulin, showed that there was a statistically lower incidence of overall hypoglycemia with a 74% reduction and demonstrated similar glycemic control. So another new thing with the new updates in the IDF-DAR guideline this year has been the inclusion of the levels of evidence. So this is an example of a grade A level 1A study, randomized, well-done study, and hopefully, this will be the harbinger or kind of a blueprint for future studies in Ramadan with high level of evidence as well. Moving to the last bit about dose changes and recommendations around that, starting with the premixed insulin first. So when premixed insulins are used, the following guides could be considered. So if somebody's on, let's say, a once daily dosing of a premixed insulin, they can take the normal dose at iftar if they're just on once daily dosing. If they're on twice daily dosing, on the other hand, they can take their normal dose at iftar, but they should reduce the suhoor dose by 20 to 50%. If somebody is on 3 times daily dosing, they should, of course, omit their lunch dose or their afternoon dose. and then adjust the iftar dose as if they were on twice daily dosing. So keep the iftar dose the same and maybe reduce the suhoor dose as such. And at the bottom, you have the algorithm or the titration schema for how to titrate the insulin depending on how the person does with this kind of altered regimen. Now, in the red on the left, there is also a consideration that if somebody's on very high doses of insulin, maybe they have a lot of insulin resistance, a smaller change to a 10 to 20% of dose may be more meaningful dose change rather than a larger change as such. The same applies for the 10 to 20% change being a relatively meaningful dose change for a long-acting or a short-acting insulin as well, of course. But those changes, if you look in the top portion of the flow chart, if somebody's on a long-acting or an intermediate-acting basal insulin once daily, they're recommended to reduce the dose by 15 to 30% and take it at iftar. If they're on the same insulin, basal insulin, either an analog or an intermediate-acting insulin twice daily before Ramadan, then they should take the usual morning dose at iftar and then reduce the evening dose by 50%, and they take that one at the suhoor, the early morning meal instead. And in terms of short-acting insulin, they can take the normal dose at iftar, omit their lunchtime dose, and reduce the suhoor dose by 25 to 50%. And then, of course, titration has to be educated upon and discussed when we are discussing any of these insulin dose changes as such, so as to find the right balance between hypoglycemia and hyperglycemia as well. And for those who are on insulin pump therapy with type 1, and we'll see a case later on about this as well, education and appropriate patient selection is essential as to when our recommendation anyway should be whether people with type 1 diabetes or an insulin pump can fast or not. If they decide to fast, then the recommendations are to adjust their basal rate. So the basal rate should be reduced 20 to 40%, especially in the last 3 to 4 hours of fasting. Now, again, the hours of fasting may be longer during the summer months in North America, for example, and so this may need to be 5 to 6 hours of fasting basal adjustment rather than 3 to 4 hours in some situations as well. And then after iftar, because of the larger carbohydrate intake, potentially you can consider a small increase in the basal rates after the iftar time period as such. And then the bolus rate, hopefully they're doing the carbohydrate counting and insulin sensitivity, and all of that can be considered. Now, what is the evidence in regards to using pump therapy in Ramadan? It does suggest meta-analysis of people with type 1 diabetes suggests a lower rate of severe hypoglycemia, hyperglycemia, or ketosis, but a slightly higher rate of non-severe hyperglycemia was seen compared to a multiple dose insulin regimen. There are currently no sensor augmented pumps or closed loop automated insulin delivery studies available. However, these should hopefully be coming in the future, and you would think, practically speaking, that these would be useful both in terms of adjustments and also in terms of warnings, etc., in terms of hypoglycemia, to reduce the risk for these people. This is the SMBG guide when fasting during Ramadan. Professor Hassanein already mentioned that up to 7 times, depending on the insulin regimen, people may need to check their glucoses. Again, it must be emphasized that finger prick testing is allowed and does not invalidate the fast as such. And then CGM has been mentioned several times, and CGM, together with education, could potentially reduce glycemic excursions and also reduce the risk of hypoglycemia, especially if combined with artificial intelligence and machine learning models potentially that are being developed. This may be the way for the future as well. There's also, if somebody is concerned about being on insulin and fasting, there's the option of a trial fast for 3 consecutive days before Ramadan to detect the hypoglycemia risk and to guide the self-titration of insulin and to find out if there are times of the day that may need extra help or extra care as such. However, the careful extrapolation of the information should be required because sometimes the length of the fasting may also determine what you do. The 3 consecutive days could be the 13th, 14th, and 15th day of Shaban, for example, may be suitable for such a trial fast. So in summary, my conclusions are that insulin can be used safely in appropriately selected people. Now we have evidence in the case of IDAC aspart, it's a high-grade evidence, largely Nu-300 as an observational evidence with low risk of hypoglycemia. Insulin therapy must be individualized, of course, considering many factors, including their previous Ramadan experience. And then self-titration monitoring are essential if insulin is to be used safely. And I'll leave you with some references as well as with the acknowledgement for all the authors of the insulin management chapter in the updated guideline. And with that, I'd pass it back to Professor Hasni. Thank you.
Thank you very much, Harpreet. Very clear presentation and quite an important topic on the insulin management during the month of Ramadan, whether for type 2 or for type 1. Thank you for this. Please send your questions, everyone attending, and we'll address the questions at the panel discussion. Now we'll move to the 4th session of this IDF-DAR workshop, and I'm delighted to have this session on the special population, which with this we are really concerned about those who have kidney problem, cardiac problem, pregnant women, or more of the older age group. And I'm delighted that this will be delivered by Dr. Luma Ghalib, who graduated from the Baghdad University and then went to New Zealand for some of her training and moved back to the States. So she has really quite a vast interest or experience from Middle East, from the eastern part of the globe and then the western part of the globe. She's now been working in Ohio since 2013. Her interest is endocrinology and pituitary, but obviously as an endocrinologist, she's well involved in many patients with diabetes, and she's kindly going to address the topic of this morning for you guys on the special populations. Dr. Luma, please go ahead with your presentation. Looking forward to it.
Thank you for this kind presentation. And I know we are slightly behind schedule, but I'll try to see if we can catch up. I would like to thank all the audience that they managed to hang up with us till the end. This is the last of 4 sessions, and my job is a bit harder because I'll be talking to you about the high-risk population. I myself have no disclosure, and these slides are courtesy of DAR and International Diabetes Federation, which I would like to thank for their generous invitation and reaching to the Muslim population in the United States, as we are still minority, but a growing minority in the United States, and think addressing their need will be very much appreciated and needed. So my job is to talk about the high-risk population. I'm talking about pregnancy and diabetes, elderly patient, people with chronic kidney disease, and with pre-existing cardiovascular disease. And as we've mentioned several times during the morning and during this session, is it deciding to fast Ramadan or not, the end of the day is the person themselves who don't make that decision. But we as a medical care provider, we can help them to make that decision, a better informed decision, and hopefully a safer decision. And the good news is between medical recommendation and religious recommendation, we share a big chunk, is that we both of us try to keep the patient and the person healthy and do no harm, which is Islam is if you really do not want to put you in harm's way. We already looked at these several times, and if you are low risk, intermediate risk, and high risk. And before DAR got involved, it used to be just like an estimation between the patient and their care providers. Now they worked so hard to create these score system that will risk stratify your patient. Where are they? And so it can help you to make a better decision and help the religious representative of your community to give a good fatwa with solid ground. This is where most of our work lie, because if it's safe, it's easy for everybody. It's very high risk. Then you really try to convince them it is too risky and you may put yourself in harm's way. But when you're in that intermediate risk, that's when you and your patient can do most of the work to get you through that journey with no major complication and problems. And then we already seen snapshots of this risk stratification tool that DAR and IDF has worked hard to create. I will be concentrating mainly on the pregnancy part of the elderly and people who have comorbidities. And if you look carefully, the population group that I'm going to be working with you on now, they're already either amber or red. So you have to pay attention to start with. None of them is low risk, and that's what I'm going to be covering. And we've seen this slide before, is that these are where the things that we can work on and your patient can work on to achieve a safe fasting during Ramadan. If it is increasing fingerstick blood sugars, if treatment modification, as Dr. Bajaj has alluded to, raising awareness, diet changes, and activity changes. So let's start with the first group, the people who are the women who want to fast while they're pregnant. So this is a very special group. And from Islamic point of view, the fact that she's just pregnant or breastfeeding, give her the permission actually to not to fast for that year and maybe can make it up at another time. But if a woman have a pre-existing diabetes and or she got diagnosed with diabetes during that pregnancy, that may affect the mother's health and the fetus health. So we have two people that we're going to need to think about their safety during fasting. So let's concentrate here on the pregnancy. So this population group, you can risk stratify them to either an amber, a 3.5 or a 6.5. And what will make it or break it is how well their sugar is controlled. If they are well controlled, then that they will drop them to the amber. If they're not within target, then that will increase their risk to go up to the red zone, very high risk. So that will take us to, that's been mentioned several times during this session, is the importance of pre-Ramadan assessment. Typically during pregnancy, physicians do not like surprises. We actually tell our diabetic patients, regardless to Ramadan, is to start to work on their glycemic control even before they think about conception. So now thinking about fasting Ramadan will add another layer of complication, is how they're going to face these long hours of not eating. So you really want to sit down and talk to them, see their blood sugar control. Do they check their sugars? What are the targets? Because in diabetes and pregnancy, you have very different, more stringent guidelines, what their targets are. And we'll talk about them in a second. And physical activity will be something main, because most of these women are healthy, young, they have other kids. So you really have to put all that in consideration, how you're going to advise them. So in general, the targets for diabetic and pregnant women is their fasting really have to be below, some say even 90. Their postprandial is very stringent guideline. We want to keep them below the 120 or 6.7. And just to keep that, to remind you're pregnant, if they're going to fast, that doesn't mean that they can allow higher postprandials when they're eating this big meal at iftar. At the same time, we need to make sure they are aware of the risk of hypoglycemia, not for them, just for them, but for the fetus too, and then want to break their fast if their blood sugars are really high, she's having hypoglycemia, if she's not feeling well, or if she noticed that the fetal movement has been reduced, and these can be the red herring for them to break their fast. Now, how often should we check the blood sugar during the pregnancy. It's what other people have alluded to, the previous speakers, but the special caveat for pregnant women is we still ask them to check that blood sugar the 1 or 2 hours after the meal. We still want them to reach that target for postprandial meal because that's critical, and that have been proven for improved outcome during the pregnancy. So this is actually the lecture of Dr. Bajaj put in one slide, and he did a wonderful job in talking about how to reduce the insulin doses for pump patient on MDIs, basal bolus, or if a pre-mix. The same rules actually applies to all exactly for pregnant women. The only thing that we concentrate on is to check that sugar after the meal, not just before the meals. So at least 4 to 5 times, if not the 7 times that we've been talking about this morning, to add to it the post-meal checking for the sugars. To keep in mind the hypoglycemia risk and the reduced fetal movement that's going to be added to their awareness when to stop their fast. Now, so that's, and I'll talk a bit more about the pregnancy cases when we go into the hands-on workshop of case to case. Let's move on to elderly patient. So we know that elderly people tend to actually try to keep their religious obligation, but they are wiser people. The studies have shown that older people do understand they have a higher risk during the fast, and elderly people do have other comorbidities that they need to think about before they fast. But age itself is not one of these risk factors. Mainly the comorbidities that they have will be the main breaker of the deal for them to be able to fast or not. Because a lot of elderly patients have renal function impairment, they have already pre-existing cardiovascular disease, they're frail, they have falls, they may live alone. So these are more important than just the age to be able to advise your patient, can they fast or not? And there are few modifications that can be thought about well ahead of the start of the Ramadan to make that decision. So Dr. Hassanein already showed some of these slides. We know that older people are the lighter blue, they have higher risk of having long term of having the diabetes more than 10 years. At the same time, as I said, they did not fast Ramadan more than their younger counterpart. And unfortunately, they do have higher risk of having hypoglycemia. And you can imagine from longer having diabetes longer, probably they have insulin deficiency, they are on insulin, and they have higher risk of hypoglycemia. The other eye-opener is for older people. So older people are the dark blue, and the teal color is the younger population. We know the older people have more hypertension. 2/3 of them have hypertension. Half of them have hyperlipidemia. 1/3 have retinal or nerve damage. Some of them have kidney problems, have a pre-existing coronary disease or strokes, and they have diabetic foot problems. So they in general, have high comorbidities and problems, and not just only the diabetes itself. We need to keep in mind what their physical activity, what they can do and cannot do. And we need to think about, can they check their own blood sugar? Because that's going to be key during Ramadan, especially if we're looking for these hypo and hyperglycemic excursion after the big meal. Can they take their medication? Do they have a good appetite? Can they keep their nutrition going on during the few hours when they break their fast? And then can they function independently? So if we concentrate on this part for the elderly risk stratification, look like it's mainly how if they do have some dementia and if they do have cognitive impairment, that will put them directly to the red zone. Are they frail? And do they have support system? Is there somebody who can keep an eye on them if they're going for that hypoglycemic episode? Are they going to be alone at home, or do they have somebody that can catch them and can try to help them when they have these risk factors? So the main other point that we need to think about during for an elderly people to allow them to fast Ramadan, can they keep hydrated? Can they take enough nutritional intake in the hours when they break their fast? Because we elderly people, a lot of them don't have a big appetite. They have GI problems. They cannot eat meal. If you're taking the little snacks they have during the day, that may compromise their overall nutritionist and hydration status. The other thing we can need to think about is we don't want to just to plot a number and say, well, you're 3.5, you're good to go. We really want to have a holistic way to look into their support system, their other medication regimen, and can they do it as a human being overall. Social circumstances, as I just alluded to, is important. Do they have people around them? Do they have a caregiver? Are they a member of a big community that can keep an eye on them to be able to support them during the fast? And then keep an eye on the complication of hypoglycemia and hyperglycemia and other comorbidities, other medications that need to be adjusted during the fast of Ramadan. So in summary, we know that they do know their limitation, and in general, there is a lower proportion for older individuals to be able to fast Ramadan in general. But at the same time, we know these are the higher risk population that have more hypo and hyperglycemia. You really want to consider the whole individual and as whole, not only their sugar control, and make sure they do have an ability to take their own medication. Somebody is there with them if they cannot, to help monitor them during these times and months of fasting. So I'm going to move on to the last two groups of the high-risk population, is people who have pre-existing chronic kidney disease and pre-existing cardiovascular disease. Well, the in general complication of diabetes, as we know, can be divided as macrovascular complication and microvascular complication. And that will be either cardiovascular disease, strokes, heart attack, MACE outcome. And then we think about it as a chronic kidney disease and peripheral neural disease and all that. But we're going to concentrate mainly on chronic kidney disease because that's linked directly to the fasting. So what do we know? So that's good news for you. I don't have a lot of studies to share because unfortunately, this is a very high risk population and there's not a lot of studies has been done on them. What we know that individuals with pre-existing cardiovascular disease and stroke are at greater risk of complication. But we know that fasting Ramadan for a pre-existing condition may not make it worse. But what we don't know is how diabetes will fit into that picture. So if you look now, we're going to concentrate on this population group, and the DAR and IDF has worked really hard in sub-stratifying patient to see where would they belong. So people who have a stage 4 with a GFR less than 30, or they're on hemodialysis or any kind of dialysis, they're really considered high risk right away, 6.5 in that red zone, as we talk about. People who have stage 3, they actually subdivide them into 45 to 60 GFR and 30 to 45 and gave them 2 or 4 as a risk factor, and you add that with the all other risk factor to come up with their total risk factor to risk stratifying them. So in general, the recommendation is you really want to receive a thorough risk assessment, not just for their diabetes, but not just for their diabetes specialist. They need to talk to their other care providers, like their cardiologists, their neurologists, especially if people who have, or a nephrologist, if they have already multiple other complications and factors going on. They do need to receive a pre-Ramadan education way ahead of time, more than the 6 weeks that we talk about. Probably they need to talk to their providers 3 months ahead of time and see if they need to do any medication adjustments. And then to keep in mind, it's not just only the insulin, it's not only the sulfonylurea that we need to worry about. These patients are on antihypertensive, on diuretics, on other medication that can need to be adjusted to prevent DKA, to prevent dehydration, to prevent acute kidney injury on top of their chronic kidney disease, and to keep in mind keeping well hydrated and enough nutrition intake to get them through that Ramadan if they decided to fast. So this is a study that's been done in Dubai Hospital, and it did show that not just the hypoglycemia, but how often hypoglycemia happens if a person with chronic kidney disease. So this is not in Ramadan. Almost half of people do not have hypoglycemia where they're not fasting, but when they fast, this hypoglycemia increased, and not just the hypoglycemia, but how often they have hypoglycemia. So as the color lighten up, that's actually worse news. They're having more than 10 episodes of hypoglycemia if they are fasting and have chronic kidney disease. So it is a huge issue that you really need to sit down and talk to your patient ahead of time, be prepared, risk stratify your patient. And with the new tools that we have with the DAR IDF guidelines, help us to try to figure out where these patients are to give them a best recommendation. In general, people with chronic kidney disease who's seeking to fast Ramadan, you really want to have an individual diabetes care for them way ahead of time. You don't want to do it last minute. You don't want to do medication adjustment last minute. As Dr. Bajaj alluded to, there could be confusion. You really may need to do more testing to make sure the new regimen is working. They recommend to actually do weekly reviews during Ramadan to make sure their kidney function is stable. You want to check their electrolyte to make sure that creatinine is not bumping up. You want to make sure their potassium is stable. Maybe adjust their diet and obviously hydration, so they can go through the month without ending up in the hospital, ER, or worsening their kidney function or their cardiovascular status with CHF. So in summary, a patient with pre-existing chronic cardiovascular disease and chronic kidney disease, most patients who have stable cardiovascular disease do not increase hospitalization or worsening of their condition during Ramadan. But we do not know if this is still true in people who have diabetes and pre-existing cardiovascular disease. Same thing. For studies have investigated risk of fasting with a pre-existing stroke. It really does not increase, but have some conflicting data. Pre-existing kidney disease or having undergone transplant, just fasting by itself may not have a great bad effect on GFR and their metabolic changes, but we do not know how that will work with diabetic. And further research is needed, and probably just need not just observational studies. We need to start working on having a more prospective, double-blinded with close monitoring to figure out if these patients are can fast or not. So larger studies is needed, and that will just encourage, I hope, the DAR group and the IDF to put more effort and more studies to keep them going and give them the momentum to keep working hard on getting us more information. Is this doable, or just say, no, it's not doable? And I would like to thank the big group and the big effort that's being put into these new guidelines that's published a few weeks ago for 2021 through DAR and IDF. to help all caregiver and patient and their loved one to make a better informed decision rather than just tell them we can't fast. And they may just go behind your back and fast anyway. And that's what the studies have unfortunately showed, that they are dedicated people, but we want them to do it in a safe way and help them to do so.
Very much clear presentation, Luma, about this special population. I invite all the other faculty members to open their cameras so that we can address the Q&A. You're right, Luma, we're a bit behind, so perhaps we can limit the discussion to a maximum of 10 minutes. So let me go through some of the questions that have been sent to us. And the first question is related to nutrition. So Osama, in your presentation, you've shown a slide of what people should eat. And there's a comment about the small piece of watermelon. And the question is, why should it be such a small piece when it's a perfect fruit for people with diabetes? I personally like that question because I love melon.
Oh, yeah, I love melon too. You know, the point is that one piece of fruit, it is not like one piece of watermelon, one piece of fruit. You know, some fruits has much less sugar than others. Mind that most of the sugar in fruits are fructose, which is a little bit safer than when you get a pure cane sugar. So, you know, if you would like within your caloric intake, a bigger piece, that will be fine. I don't think that the limitation is by the piece, it is by the amount of calories per day.
Thank you, Osama. There's a question coming to me related to the point of the risk factor for those who have hypoglycemia before Ramadan. And obviously the person asking the question is right. This is something that very much patient education is very important here, but not just patient education, but potentially treatment adjustment, whether the type of treatment or the dose of treatment or the timing of treatment. So if the person in normal days, when we all eat perhaps every 3 hours or even less, gets hypoglycemia, then obviously not eating for 17 or 18 hours or 16 hours as the current fast in North America would possibly be, then obviously that person is at risk. And that's what we try to address in the risk quantification, and equally in the presentation of Dr. Bajaj about how we need to adjust. I guess the next cases would be an important point of this. Many are asking about the videos and the slides. Certainly the video should be available for everyone to benefit from, and the full PDF of the guidelines is also available. Guys, have a look at the questions in case you find a question that is relevant to you. Please take it forward.
I see a question, Professor Hasneen, if I may. The question is from Morgan Lincoln. Thank you for that question. The question is, will Diabetes Canada be adopting the new risk stratification tool? So this risk stratification tool is a great advancement from the last risk stratification tool, as Professor Hasneen already detailed. And it actually takes it's a global tool now. That's the other thing about this tool, because one of the questions is about the number of hours that are there for fasting as well. So it no longer is only dependent on the person characteristics as well as the medication characteristics, as the previous guidelines said, but also on a lot of other social context to that as well. So as you are probably pointing to, Diabetes Canada with Professor Hasneen came out with a position statement around diabetes and Ramadan from Diabetes Canada, which talked about the tool, the previous tool, and so I think this would be the next update that should be there. Now, whether we do it formally or not is probably a matter of just formality at this point, because this new update is actually more applicable and to a global audience as such anyway.
I think I'll take that. I know we have only a couple of minutes. There's a question, Kathy Lee. They're asking about if the hyperglycemia is caused by glucocorticoid, if somebody have a brain tumor that's taking steroid. You just have to be really rational. If a person have a brain tumor and they're taking steroid and they're diabetic and they want to fast, probably they're not in, I would put them in a maroon zone, not just the red zone. So you really have to be rational. But if they think they're stable enough and they're fasting and their sugars are fine, I guess they just take their steroid with iftar. They take the fast-acting insulin. They take a long-acting insulin that to cover that, probably an NPH to cover that glucosteroids if they're in prednisone. If they're in dexamethasone, then that's slightly different. You manage them the same as you would manage them, is just move everything from morning to the iftar, which is the biggest meal, and you manage that. But you just have take a holistic approach to how you deal with people's wishes and what they want to do.
The question I'm diverting to you, Osama. I don't know the person who's asking it, but it's quite a nice question, because the person is saying, if a patient has been fasting for a number of years successfully without the input of a healthcare professional, how would you implicate the healthcare professional to interfere now?
Yeah, I actually picked that question because it's very fundamental questions, and we have been asked a lot about it. Mind that the role of primary care physician or physician in general, or specialist, is to help people to have a safe fasting without hypoglycemia and with better glucose control. This is our major aim. We are not intruder in their management. We are advisor about their management. But you have to remember that diabetes is a progressive disease. People over years, they have more duration of diabetes, more complication of diabetes, more medications. So the role of a specialist or a physician is to ask patients about their previous experience and then ask them what is new that they had been using this year, if their blood glucose at the same level, if their testing of blood glucose had been changed, compliance, eating, weight. There is a lot that you can ask and give better advice. If you don't have any good advice to give and the person is doing very well, that's fine. You just say, congratulations, fast Ramadan, I'm supportive, and if you need any help, just let me know.
Thank you very much for this. I think I entirely agree. It's about systematic approach. We have a number of aspects that we need to go through, and one of them is the person's own previous experience. So if the person is happy and indeed they are well controlled without much of hypos, without much of comorbidities, then we just congratulate them and carry on. But if there is room for improvement, some advice that could be done to make things even better, then of course we need to interfere. One question is about, I think it's about how can we fit the 4 to 6 liters per day. I don't know what do they mean by 4 to 6 liters per day. I mean, normally the fluid intake is a bit less than this. But
6
anyhow,
to 8 glasses, what we suggest.
Yes, I think it's 4 to 6 glasses, and obviously we want to spread them. I see from my personal social life, some friends or relatives in the last half an hour or 15 minutes before fasting start, they are drinking a large amount of fluid. And I laugh and say to them, only camels can retain fluid for a long time. So what you will do is you'll be rushing to the toilet after an hour or two to urinate much of this fluid. So it needs to be done throughout the eating hours or the drinking hours rather than at the last minute.
And if I may just add one comment on the previous question, is how to approach your patient if they're happy and they're not asking question. Unfortunately, at least in the United States, a lot of people don't talk about their religious practices. They just feel probably isolated or discriminated or however you want to say it, but they really do not feel comfortable opening that topic and not even discuss it with anybody. Doesn't mean they're not suffering, doesn't mean they're happy, they just don't talk about it. But being a healthcare provider that's aware of this issue, and just open-ended question, just ask them and let them steer how much they want from you, but just open it up and let them express what they have, rather than just, if they didn't ask, I'm good, you turn around and leave the visit and everybody's happy.
This is a crucial point, Dr. Ghalib. I remember when I was visiting the Swedish Diabetes Register, which is the largest diabetes register globally. And I asked a question about religion, and they said, we don't record religion. It's something personally. Sometimes too much of political correctness could be harmful. And what I personally feel is, if I'm asking my patient in a nice, friendly way, that whether they are fasting Ramadan or not, and a reason for me asking is, if they are, I might be trying to help, to providing advice or adjustment that relates to this, I think the person would welcome the question. But obviously the opposite applies.
Mohammed, if you don't mind, I personally like what Dr. Ghalib mentioned, because we had been doing our practice in the US for more than a quarter a century now. I would like just to say that it is very important for every physician to be aware of different cultures. This is very, very important to a degree that in the American Association of Clinical Endocrinologists, we created a new chapter now called the Transculture Diabetes Group. So the whole idea is you have to know piecemeal, especially in the metropolitan areas like in Canada and the US. People are coming from all over the globe, and they have their own culture, their own religion, their ethnicity stuff. So I would like to advise every physician who's hearing us now to open their mind to different culture and try to understand.
Absolutely. If I could just
working in Canada and being involved with Diabetes Canada.
Yeah, if I could just add, I mean, being a non-Muslim physician, I think it's very important that we as non-Muslim physicians also, learn about all the evidence and the guidance because we care for so many people, so many Muslims who do fast. And so it's very important that this education not just be limited to the physicians who are with that religion. So it's very important to do it cross-culturally. I'll also take it to a different context as well. When we ask so many different individual social contexts for the person with diabetes, for example, are they working evening shifts, night shifts, and we adjust their therapy accordingly. Similarly, this is very important to help them do what they want to do, what they wish to do that safely. It's very important, this education piece. So thank you.
Thank you all very much. I think we've answered roughly all the questions. There was one comment from one person about the importance of the role of the nutritionist. Definitely, our guidelines is multidisciplinary and our practice is usually multidisciplinary. The role of the nutritionist in Ramadan or anyone with interest in the topic is really crucial. It's fasting and feasting, unfortunately. So it's important to, as much as we eat the right things to avoid the problems while we're fasting, equally it's very important to avoid the overeating and the feasting. I don't see any other questions that we have missed. Are our faculty happy that we've answered all the questions? Okay, so with this, I would close that session of the IDF-DAR workshop supported with an unrestricted grant by Sanofi and Servier.